Practice, I don't do anywhere near much immediate loading or placement or function with partials as I do with single teeth and full arches. The reason that is a bit of single tooth you can often keep out of occlusion. With full arch, you can never keep out of occlusion, but they're splintered to each other for support. With a partial, it's sort of in between. So, A, the tissue is not as critical, you've lost it usually, and B, you don't lend yourself to doing what you can do with singles and full arch. Although I still do enough of them, but basically for every partial case, anterior partial I'm talking about, for every anterior partial I might do immediate functional loading, I'll probably lose 6 or 8 or 10 of them with single teeth or full arches. And the concept's the same. So what I'm going to do is go straight on to full arch cases, e.g. that, and that. Just a few examples. Okay, now, look, we start with sort of full arch up to full arch lower. There's a number of options. Okay? And these are all the options. We just do the mandible first, maxilla similar. What we can do is do 5 implants, 3 implants in the interforamina between the foramen on each side, and 2 implants, one each side distal foramen, that's the first, second mole or whatever. The other option is to do 5 implants, but all between the mental foramina, which is how this whole thing started. Or we can do 4 implants between the foramina, but they're straight up and down, or the so-called all-on-4 concept, which is all about, we talk about. Or you can do an overdenture. Now, I don't do too many overdentures. It's just nature of my practice, nature where I put myself in a corner. The sort of patients I get generally something's fixed. And so, you know, I say I don't talk too much in the way of overdentures. So here's sort of my preferences, if you like. There's option 1, 5 implants, 1 implant, implant stack, 1 implant distal for each foramina. The advantage of that is you get tons of space for cleaning, you get virtually no cantilevers, and, you know, so if I could do that every time I would. The problem, of course, is often in the mole region there's no room to place an implant because there's been more absorption, and then, you know, if you're the old nerve is in the way. If I can do it, I'll do that. The other way is we can do 4 implants between the foramina, but straight up and down. Probably you end up with slight, you know, can end up with large cantilevers, or the all-on-4. So, you know, I have guys who I'm saying, all on 4 is the cat's cry, the cat's cry, that was a Freudian slip. All on 4 is the cat's cry at the moment, and, you know, said in the newspapers. We do a lot of all on 4. We also do a lot of the other stuff as well. So this is sort of option 1. You can see there, you know, no cantilevers, well spread out, you know, it's good soft tissue. This is useful, so people sort of think, all they can think of is tunnel vision, they're all on 4. Well, you know, yeah, you'll see lots of all on 4 in a minute. But if you want to extend the occlusal plane back to the sort of second moles, because the patient's got parafunction, or they've got teeth and jaw problem you want to support, or they've got the opposing dentition going into the 7s, then really we can start looking at extending these further back, if possible. And that minimises cantilevers, it promise you it reduces breakages and maintenance. Okay, I'll show you. The thing with that is the sort of by the by. If you're going to go back there with short implants and you're going to load them, that's not such a good idea. So if you're going to go, either don't do that and go just into foramina, or alternatively put those on and stop the provisional prosthesis there and put these on later. So you put the implants in but not load it. Okay? So you can get 5 implants between the foramina, e.g. all these cases. There's an older case, how can we tell? Because it's gold, not titanium. The more you know, the more you can sort of pick things up. That should tell anyone doing implants, he's oh, that's gold, that's been a pretty while. The other way is, like I said, you get 4 implants which are straight, but you get longer cantilevers, high maintenance. Okay? And then the all-on-4. The concept of the all-on-4 is that on the lower, you avoid the bent foramen, but you can angle that and you can go further back with your occlusal plane. And you get this elbow, if you like, where you can angle the button that corrects that angle. Sorry. On the upper arch, the concept is that that's where it really started, is you avoid sinus lifts. What you do is, the angle, the anterior implant follows the anterior wall of the sinus, and because the anterior wall of the sinus, it can be, you know, a huge range of angles. You find a huge range of where these angles these are. There is an actual device where the surgeons can use where it tells you the angle that you're supposed to do. You start from the top of one line, the bottom of the other one, or one next to it. I've seen the guy, my surgeon uses one, so you can take a photo. The rest of it is like, so, these are all my cases. They're all 4 different cases. This is 4x4x4, not just all on 4. It's like the orthodontists talk about having, the pre-molars out before orthodontics. It's called 4 on the floor. So these are 4 on the screen. You can see the different range of angles. That thing's almost kind of flat. That thing's almost vertical. And these are much shorter. So there's a huge range of these, and depending on the situation. Okay? These are some of these. I saw this in the newspaper every second day, and there's these male clinic advertising all on 4. That guy's advertising all on 4. They're all on 4 there. If you read the fine print, the procedure can be achieved in as little as 4 days. Well, I'd like to see that because they all get provisions for starters. These guys obviously don't. And when you see some stuff down the line, to do this in 4 days is cutting a few corners, shall we say. So you need to consider how far back you want the occlusal plane. Aesthetics, they might want more. If you've got a Julia Roberts smile, you're not going to stop at the 4s or the 5s region, you're going to stop at the 6 or 7 region. Again, if you want a parafunctional TMJ problem, chances are going to go further back. Again, depending on the load the opposing dentition does, is you might decide you don't want all on 4. And it depends how far the distal cantilever is, depending on where those distal implants ended up, based on where where the canal is or where the anterior wall of the sinus is. So in terms of the upper, same sort of thing almost. You do all on 4 or 6, or you do zygomatic or quadzygomatic or over dentures. So we used to say, you can do it all on 4, or you can fix on 6, but the bank said will grade on 8. So, there's a whole range of things. You need to assess exactly the same thing. Okay, so occlusal plane, aesthetics, closing dentition, etc., 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 and the anterior wall sinus, that angle. Okay, so they're pretty big cantilevers there. Pretty big cantilever there. These are provisionals. Once you start to know, see that's a permanent bar, and that's a provisional bar. Like I said, with the provisionals, we don't go too far back in terms of cantilevers. There's the provisional, there's the final, different cases. So they're all on 4s. They've got 4 implants, 4 abutments, the traditional one. 2 of these are angled abutments and 2 are straight abutments. So you need abutments. I virtually never use abutments. It's always implant level except for the full arches. And you have to use abutments there to correct the angle. Simple as that. So there we go. There's 2 angle abutments. They look different. There's 2 what's called multi-unit abutments. Same on the lower. Tissues look good. The alternative to that is here we've got 6 implants. Here we've got zygomatic or quadzygomatic implants, and here we've got quadzygomatic with 2 implants at the front. And they're nice. They're fun to do. There's your zygomatic implant. These implants here might be long, but these ones might be 10, 12 mil. These ones are 35 to 50 mil. They go in zygomatic mode. They're not curved, it's just the OPG screw. That's how it looks. That's how it used to look. So there's the one with quad zygote plus 2 anteriors. The original zygomatics used to have just a zygomatic on each side, then they went to quad zygote, 2 on each side. And it was actually Pat Henry that decided that the too large a cantilever going anterior, it's not really cantilever in the strict sense of the word, like hanging off the back. There's too much of the fulcrum going forwards between the distal implants at the front, so he started putting 2 at the front, courtesy of Pat, and then everyone else followed. But remember, as fancy as this is, and the surgeon does these, I don't think anyone here is going to be doing zygotes and quad zygotes. Once the abutments are connected during surgery, so when the restorative dentist comes to restore the case, all you're seeing are these abutments. You're not seeing what's up there. Okay? What you do is working with that, almost like sort of any other case. The other thing with zygomatics is that they need to be splintered. They need to have cross-arch stabilisation because they're so long and flexible. I won't go into that right now. and we make sure they can clean them with all sorts of things. So this thing here, I don't know if you're aware of this, this is sliced bread, was invented by a dental therapist in Queensland. It's been out about 3 years now. It's called X-Tape. There's X-Floss, there's a thinner one of these now. Anyone wants to know, speak to our young therapist there, Erica. There it is there. So you get that thing. These are really good cleaning aids. So you can clean it like that. Now, look, the other thing is to minimise cantilevers. Like I say, I've seen a few breakages, and pretty much every one of them has been around the distal implant, distal button, because that's where the weak point is. Okay? So we try and minimise that particular provisionals. And I've got about 10 slides on this, which I kind of pushed to the end. And if you've got time, we'll show you those. It's a very, very interesting sort of little topic. So we'll show you after or something. So we try and really minimise cantilever. That's the reason. There's one there somewhere. There's another one. There's another one. Okay. So the question is, how do we get from that to that? Like I said, with single teeth, we do the impression, which is the duralar registration, and we go to the lab, reconstitute the model, and then insert the visual data or two later. With the full arches, I have done on a couple where I've inserted like a day or two later. The lab technician has been up all night doing it, but then if you knew the patient, you'd understand why. So how do we get from that to that? If you want to get from that to that, the best advice I can give people are these three things. Number one, these are a bunch of surgeons I've used over the years. You want a surgeon that knows what he's doing, okay? And I use one surgeon all the time, but I've used it in the past, I've been doing it a long time. You want a surgeon that knows what he's doing, and he's used to working with and knows how to do whatever he needs. Secondly, need a technician, when he gets to the lab, he knows what he's doing. There are plenty of fantastic technicians out there that are good crown bridge, but don't do much in the way of implants. That's not the guy you want. There are plenty of great oral surgeons that do orthodontic surgery, removal of wisdom teeth, etc. But they don't do much in the way of implants. That's not the guy you want. You want a guy that has done lots and lots of implants, and the lab is the same. You also want a company, okay, this is no blame, but I'm sort of stuck with them, I don't think like that, but you want a company that's got all the componentry in the backup that can deliver what you want. And not all companies are created equal. There are plenty of companies there that you can't, not too many companies do zygomatic implants or angle buttons, or etc. So you need to know the hardware. The other thing is, they all have their little nuances, and you're really better off to sort of stick to Stratton, Biohorizons, 3i, Astra, etc., and get to know it really well. If you chop and change companies a lot, you're going to get burned. I'll guarantee it. Now, there's different ways of doing it. We're just going to talk about the immediate way, because that's what we're talking about tonight. Okay? So you do it traditionally, you do one step at a time. You do a stage approach, you do guided surgery. Basically, there's three stages: what you do before surgery, what you do during surgery, and what you're doing after surgery, i.e. in the lab. Okay? So we'll have a look at those. Prior to surgery, the bottom line is what you want to do is a full upper and a full lower, you do both, a full denture setup. Just think of it like that. So you need to do a full on full denture, or full upper denture, or full lower denture, or both. Okay? That's your starting point. Okay? Now, if they're dentureless, they may have dentures and they might be satisfactory, in which case you duplicate them. If on the other hand their dentures are not satisfactory, then you've got to make a set, which you're never going to use for the same criteria. So you don't have to worry quite so much about, say, secondary or final impressions, but you need to have all the other criteria in terms of tooth position, vertical dimension, height, tooth colour, because you're going to use that for the provisional, midline, etc., etc. Okay? So you do a full set of dentures. If they're full and satisfactory, you can duplicate, and you can also try your tooth setup just like a normal denture. Okay? If on the other hand they're unsatisfactory, duplicate it. On the other hand, if they've got all or most of their teeth, you can't try it in because they've got their teeth coming out in surgery, implants and provisional going in straight after surgery, you can't try those in. You've got to be that much more careful with those because, you know, if you try these ones in and there's a problem, you change it, just like a denture trying. There's a problem here, you won't find out till we do surgery, it's too late. Yeah. So prior to surgery, got diagnostic cast, and one of the things, like I said, with the single teeth or partials, always keep a set of originals. Always keep a set of originals. Okay? So here we go, and blah, 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 we're going to do a full denture. And then with a partial case, you know, they're coming out, there's I think 2 teeth left. Yep, 2 teeth left. You can still try it in, you can still try and check the midline, your occlusion, your tooth, etc. So you can do a sort of almost a full try-in. Okay? If you're doing that, a trapezium place, make sure to confirm and mark the midline, because the midlines often might be off in these. You don't go on the midline of this tooth necessarily, or the lower, you mark the midline of the face. I've been burnt many years ago in the past, where you know the provisional is going to be based on this setup. If that midline's wrong, your provisional's going to be wrong. So you might mark the midline halfway through this tooth or halfway through that tooth. So you can't do it